I was tasked to say DK Crush is just another bifurcation strategy. So I looked for a long time to find a way to prove that this was right. So let's see if I did some justice to this. My disclosures. So first and foremost, I'm going to say I was not supposed to be debating Manos. I was supposed to be debating Ashish, right? So initially it was supposed to be like, all right, fine, we'll just do a Bollywood throwdown, we'll make stuff like that. But so as you can see, I'm putting humor slides in the beginning. That's a bad sign already, right? So
you're Salman Khan in that.
That was. I can't say I was Salman Khan. I'm not going to say that, but sure. So really, we're going to start off by saying the provisional versus the two-stent strategies. Okay, so we all know, as Manos has said, freedom of maze, one versus two stent, we know that one stent strategy is typically better. The data is very clear on this, albeit DK Crush 5, made it seem that DK Crush is better than provisional. I'm going to try to make that not true. Restenosis at 2 years, you look at bifurcation versus osteal and shaft lesions, you can see here single versus two-stent strategy. If you cross over, you're still better than going up front with a two-stent strategy, but this is all pre-DK Crush 5. So now you decide to go to a two-stent strategy, and this is essentially what the scenario has been for years. We have a lot of choices of how to do it. It's boiled down pretty much to, as Manos said, Culotte and DK Crush. The question becomes is, what should we really do, and does it really matter? And it really just breeds confusion. And the confusion doesn't just stem from Manos' 17 steps on how to do DK Crush, but the confusion is multifocal. So there are really three choices. One, you want to keep that side branch open. You want to do provisional stenting ideally. And then now we decided, okay, we're going to do two stents. So the risk of the one stent technique, as we all know, provisional stent approach is you possibly lose the side branch. Two stents, well, you could take this two stent approach, and if you really don't do it right, you can box your car up and you'll probably never get back into the side branch or something else bad will happen. The key is that branch, and I think this is the most important piece of understanding. Is it for all bifurcation lesions, is a two-stent by DK Crush strategy the right thing to do? Medina classification is really not enough, as was mentioned. Length of disease, whether it's focal or diffuse, is very important. The size of the side branch, is it stentable, is it not stentable, is it small? Even distal left mains, not all proximal circs are 4O vessels, so it depends on the size of that distal left main bifurcation, circ and LAD. The relative size of the main branch, how much myocardium is at risk? This is very different to do a distal left main bifurcation than it is to do an LAD diagonal bifurcation. But are all these bifurcations really the same? And I think that's really the key here. How difficult will it be to rewire the side branch? Again, a very important piece in deciding whether or not you want to do a two-stent strategy versus not, and what two-stent strategy. The angle of the origin, right? So if the angle of the origin is greater than 70 degrees, which two-stent strategy is better? And if you're going to do a two-stent strategy. And this is really a simplified approach, as we all know. It pretty much goes through in terms of, again, provisional stenting is really what we both, Manos and I both agree, is really the first line therapy. But if you're going to go to two stents, here's the options. Culotte stenting, really with the side branch stent first, with a mandatory pot, systematic T-stenting, which really has gone away, and really DK Crush, which has really taken over based on the more recent data. And the most important thing, as you can see here across the board in the end, is a final kissing balloon inflation. So deciding which two-stent approach. So will you be able to rewire the side branch or the main branch after the first stent is placed? If it's a no, then I have to say, to be honest with you, DK Crush is probably the right thing to do. But if you are going to be able to rewire, the angulation is near a right angle, greater than 70 degrees, then maybe you don't need to do it. And so you can do a T-stent or a TAP strategy. But if it's not, the side branch and the main branch are really similar, then you go with a TAP, DK, or really a Culotte, which has really become the mainstay of therapy. And if you really can't, the main branch and the side branch are not similar, then obviously a DK Crush, or similar, the DK Crush may be the better way to go. Obviously, we know that there are dedicated stents that we could potentially use. So why is DK Crush better? Is it easier to cross back into the side branch for the final kiss? Yes, I think that we can all agree. It is probably the easiest way to go back into your side branch after you perform a two-stent strategy, without question. I don't think that is without question. I'm going to concede on that one. And we know that your crush no kiss evolution versus the crush and kiss evolution to the DK Crush. Right? We've seen these images, and we clearly feel that DK Crush is the better way to do this. But is it really better for all complex left main PCI lesions? Well, this is what I'm trying to say, is that it depends on the angulation, depends on the side branch, depends on the vessels. But in large vessels, it definitely is. And I put Manos' paper in here because I took a line out of it. DK crushes many steps and it'd be challenging to perform. He sort of proved this for me, so I appreciate that. Saved me one step. And there's another line from it says, and really you have to understand that the volumes that were performed in DK Crush 5 were operators who did more than 300 PCIs for 5 years straight, including at least 20 left main PCIs per year. And as in the editorial, it pretty much says, and we have to agree in the United States, these numbers are just unrealistic. And we all know that the volume numbers, this is not realistic for the majority of operators in the United States. So imaging tells the whole story. This is a real case of a DK crush, right? So this is not the imaging, the OCT and IVUS imaging that you would expect to see, right? And my pointer's not there, but as you can see here on the left in A, B, and C, you can see here that after all the kissing balloon inflations, you do not get a perfect ostial and a side branch stent in that location, right? So, and this is real life, real patients, real story. So what do we do? So the European Bifurcation Club has a statement, a consensus statement that said, in left main disease involving both branches, the stent technique should depend on the individual patient's anatomical characteristics, operator's skill, but a provisional strategy may be effective. And actually, it does not give DK crush a class level 1 evidence A indication. So what about these non-left main? So one piece of the DK crush that I'm wondering, and I'm curious what the panel has to say, is what balloon do you use, what size balloon do you use to crush that first stent? That's not really outlined that carefully, right? What size do you use? You 1-to-1 size in the main branch? Do you potentially dissect the vessel in that scenario? What about the balloon sizes when you do the final kiss? What sizes are those supposed to be? There are these details in the performing the procedure that are sort of left to the operator, but unfortunately those details actually matter. And in the end, I have to say my mentors and my teachers always taught me to keep it stupidly simple or keep it simple stupid, right? And I think this is very important that when you have a 17-step strategy, unfortunately it's not simple. And I'll tell you from my own cath lab, my own colleagues, who they claimed they did a DK crush in a patient, when you actually review the pictures, there was no DK crush. Okay, so this is the problem. And I think this goes back to the imaging question that was brought up earlier, is that we can say we do things, but we don't actually do it, then we're not really doing justice to our patients. Thank you very much.